Tate Chronicles now transmitting.
Welcome to the Tate Chronicles on Healthcare Now Radio. And now, here's your host, Jim Tate.
Good day, citizens of the free world, from border to border, coast to coast, and to all the ships at sea. I bring you a warm welcome. This is your correspondent, Jim Tate, and thank you for tuning into the Tate Chronicles. Join me as we cut through the fog that exists at the leading edge of healthcare technology and culture. I'm really pleased today. Someone I've known for a while, always enjoy talking to, and that's none other than Ritesh Ramesh, the CEO of MDaudit. MDaudit is deeply involved in billing compliance and revenue integrity with a single data-driven solution. Ritesh, thanks for joining me on this episode of the Tate Chronicles.
Good morning, Jim. Good morning to all the viewers. Great to be here and happy to have this conversation.
Yeah, there's a few things I want to dig into, but first, let me ask you this. I know that MDaudit finalized acquisition of Streamline Health Solutions, last August. And it really adding that Streamline's functionality to bridge some of the crucial revenue cycle management issues. How's that going? How's the combined platform changing the landscape?
Yeah, it's a great question to start this conversation, Jim. You're right. It's been almost coming close to a year on that acquisition. And if we take a step back and reflect on why we did that acquisition, there are two perspectives. One is at MDaudit, we always believe that revenue risk and revenue opportunities are two sides of the same coin, number one. And we have been pioneering this approach of both pre-bill and post-bill solutions to our customers. So from a product fit perspective, it made total sense because Streamline had a couple of products which were just pre-bill only. So from a product fit perspective, we are really kind of pioneering that risk solutions and revenue solutions approach in our portfolio. And then from a customer perspective, it was a much more a perfect fit because they sold into the same customer segment as MDaudit, number one. And actually, there's a 50% overlap between the Streamline community and the MDaudit community. So the integration's been going really well. We are almost at the cusp of completing it and integrating the products into the portfolio. And we have had great feedback from both customer bases in terms of how this story kind of resonates as multiple functions within the health system come together. Billing compliance, HIM and coding, rev cycle, all of them are in it together to solve the revenue integrity problem. And our platform represents a portfolio of solutions which just does that, which helps those functions to come together and collaborate to solve the issue. They might be looking at it from a risk perspective or a revenue opportunity perspective, but they can consume it all from a single combined platform.
Who are your customers? Are they large practices? Are they large healthcare systems? Is it all the above?
Yeah, great question. We have like three large segments. One is large health systems and IDNs around the country. We serve a lot of regional health systems and hospitals as well. And then the third piece is the large physician network groups. So those are the three segments we serve.
One of the things that I'm fascinated about, we almost hear it too often these days, Ritesh, is AI. So how are you seeing AI really currently bringing benefit to RCM?
Yeah, it's a great question. We have been on this journey for the last 4 years, I would say, and we have had a lot of hands-on and practical experience in embedding AI into the MDaudit platform. So my perspective is a simple and concise kind of view I have is AI drives efficiency, and that's how a lot of leaders within the health systems are looking to implement AIs to drive efficiency and take costs out. They want to reduce process friction within the rev cycle. So I would say those are the two core strategic goals or imperatives for most of the health system leaders is how can AI drive efficiency and drive some hard dollar ROI. And then if it really optimizes and reduces process friction, it helps me get the job done faster. So those are the two key things. From an MD audit perspective, we have been on this journey of implementing AI and really kind of driving adoption for our customers. And the two or three things I can tell you is, number one is there are a lot of use cases within rev cycle, which I call it as transactional RCM, which could be very well be for autonomous AI. But then there are use cases which are heavily regulatory focused and clinical focused that needs humans in the loop. And within MD Audit, we always make sure that we have humans in the loop because we have customers who are really kind of in that regulatory kind of cusp, looking at payments, billing, coding, and we just don't want to introduce more risk into the equation. So we implement it in a way where our customers can get both all of the upsides, which is how can we drive efficiency by implementing AI to drive automation, analytics, but also at the same time make sure that there are humans in the loop to ensure that the AI doesn't create more risk in their existing processes.
Let me kind of give you a scenario. Years ago, I worked in the clinical side of a large pulmonary practice. And I wasn't really aware of the billing side of things very much. But the one thing I knew was that if there was a rejection or denial, that kind of was dumped into a black box, essentially, and people were told, oh, go work those denials when you have time. And so there was no kind of on the front end attempt to identify errors before those claims were sent in. So talk to me a little bit about that kind of preventative front end, real time.
Yeah, it's a great question, and that's one of the reasons why the pre-bill solutions are so important, because most of the systems are kind of dealing with denials after the fact. They've happened, and many of them are in this kind of constant journey, and they're exploring pre-bill solutions because they want to really push this upstream to make sure that they catch it as much as possible in the upstream processes so that they can correct issues with the billing and coding, and even some clinical issues before they can send the claim out to the payer before it gets denied. So, but I would say that there are some good examples of many of our customers who have implemented pre-bill solutions. And the biggest insight is implementing pre-bill solutions might look easy, but the key thing is you just need to make sure that you optimize your existing processes so that it can accommodate pre-bill, number one. And number two is, for you to implement good pre-bill solutions, you need some good post-bill analytics. So that, think about it as you have some good insights from your historical data that you can use that to apply prospectively so that you can get some foresight. So that's how we play both post-bill and pre-bill next to each other, because with more increased insight, you can anticipate where your issues are, you can catch them pre-bill, fix it, and try to do a good job in making sure that the denials are decreasing.
Those denials, when they come back, there can be certainly so many reasons why there's a denial.
Right.
Explain to me, or kind of lay out how AI can examine those denials and identify maybe themes or processes.
So that's one of the strongest strengths of AI, is to glean through millions and millions of denial data, and then it can really kind of find you that needle in the haystack, where you can focus on the 20% of the things that drive 80% of your impact. And this is one of the biggest challenges for most of our customers who are dealing with multiple facilities. Those could be inpatient or outpatient. They're dealing with hundreds of payers. They have multiple coding groups, positions. I can go on and on. It's like one to many from that
Yes.
perspective.
Sure.
And everybody's asking the question that since my resources are very limited, I cannot throw 3,000 people at every problem. What can I do to really find that needle in the haystack so that I can first understand where my biggest opportunities are, and then they can go and solve it? I think that approach is wise. That approach makes total sense because, again, as I said, ultimately you have limited resources and you want to make sure that they are focusing on the right problems. And that's where AI can really help. And we have done that. Is today we benchmark against 15 to 20 billion denials records.
Wow.
And AI is I would say, fast when it comes to gleaning insights from that scale of data and putting things in front of you in seconds that are actionable. So that is the key strength of the technology. And of course, it can serve things up to you, and we still think that humans need to be making the decisions. So that's the best way to use AI in humans is, it can really glean that information, serve those analytics and heavy lifting of data analysis, and then humans can really act on them. So that's a great model for people to pursue.
What are some of the major reasons for denials?
So we produce annual benchmarking report every year. And that report comes out in around end of November. And the reason we do it in end of November is for two reasons. Number one is our user group meeting every year is in November. And then we wanted to release it in November so that we can look back for the entire calendar year and then give customers something which they normally use it for the next year's strategic and operational planning processes. There are 3 or 4 things which we see from last year's report. One is if you really look at the coding related denials. So when we saw it before 24, when we compared 2024 and 2025, the coding related denials were through the roof. They were like 125% year over year. And then when we really looked at last year, which is on top of that 125%, there's an incremental 25 to 30% increase. And then not only we look at a lot of data sets which are like denials coming from payers, but we also have data from payer audits, which we can look and get some insights. And the payer audits, which are basically post-bill audits, even for the ones that the payers have paid you, and then they come back and ask you questions, what we see is 90% of those payer audit kind of reasons in the last 6 to 8 months is billing and coding errors. So I think what we have been thinking internally is there's been a lot of conversation on autonomous coding and AI-driven coding. And if those are all true, and it should be driving a lot of outcomes at the back end. But what we have been seeing at the back end is huge 25, 30, 40% denials when it comes to coding, and specifically outpatient coding. So we have been thinking through what's driving that type of denials and what can we do to provide some good revenue integrity and coding integrity kind of workflows and solutions which can help customers stop things before it becomes really bad. Because again, this is a great example of not just using AI for just using AI.
Right.
It's totally possible that the health system can say, look, I'm using AI upstream. I'm able to code more claims. I'm able to push throughput and velocity. But how good is that if you push throughput and velocity, but only if you don't know what's going on at the back end when your coding denials are increasing 10, 20, 30, 40%. We have been reading a lot that payers have been focusing on coding intensity, where they're able to look at coding at the population level and really kind of trying to figure out why is coding intense in a level 3 being coded at level 5, for example, or a level 4 being coded as level 5. So that's one key example. Our theme is around coding, where coding-based denials are through the roof. The second trend which we saw was all around medical necessity and information required. So you might get all your coding right, and payers are coming back and asking questions around medical necessity and payer policies, and that's been a source of tension between payers and providers. And then last but not least, we have heard about pre-authorization, and now you saw the recent announcement, which is pretty positive from United, that they're going to reduce the number of pre-authorization for some of the services.
Yes.
So those are the three trends I would describe as coding, medical necessity, and then, I mean, it's obvious on the pre-authorization side.
You know, when you speak of coding, are you talking about somebody has, like, maybe if it's an ambulatory visit, there's been a payment submission for a high level visit, but there's not the underlying documentation. Is that the kind of
Yep.
coding you're talking about?
That's a great example. I think that's one. I think that's one of the use cases, is where you have coded something where you don't have relevant documentation.
Yes.
And that's where AI can again play a big role. And we have seen a lot of solutions in the space, which helps you kind of identify what those issues are so that you can actively fix them. That's one example. The other example is it's both on sides, right? In places where you're submitting something which you don't have proof of documentation, but then on other cases where you do have documentation, but you're not coding the appropriate stuff.
Yeah.
So it's almost like you're leaving money on the table as well. So could be documentation related, number one. The second piece could be around what are some of the policies? So for example, was this procedure done at the same care setting as the policy says? You have heard a lot about the inpatient only list, and now people are trying to talk about site neutral payments as one key concept that is being floated. But I'm just saying that the payer policies are coming into play because they're also looking at, hey, was this procedure done at the appropriate care setting? Do you have any errors in your claim? So documentation is a great example where it can go either way, where you are either documenting something and not collecting, or you're collecting something which you're not documenting. But then there are other reasons where you're not following the right protocols for coding. And then there's a chance for them to just deny it, to say, go back and fix these 5 things. A simple example we have seen, which might be silly, is you might have some claims where the date of service is preceding some other date, where they say that, look, why this is not even logically possible. So these are all informational errors in your claim, which tells you that your scrubbing is not as great as people think, for example. So we see all kind of issues, medical necessity as well, related to this topic.
To our audience, if you just joined us, I'm Jim Tate, and on this episode of the Tate Chronicles, I'm speaking with Ritesh Ramesh, the CEO of MDaudit. Something else I'm kind of interested in how things work. So I'm sure sometimes there are denials just based on confusion about who to send the claim to.
Yes.
You know, sometimes in accidents, whether it's workman's comp or insurance, or who the responsible party is. And I imagine when situations like that occur, hopefully, eventually they get resolved. But these unique cases may not occur very often. So for the software, AI, if it's used, to be able to look at a lot of those and know on the front end, this is probably going to be a problem. How do we address it?
Exactly. I mean, what you said is a great example of things that needs to be caught at the patient registration front end piece of the puzzle.
Right.
In terms of who's the primary insurer, who's the secondary insurer, is this patient self-funded, for example, are they in Medicaid? So all those things have to be resolved at the front end, and it just passes through the front end. And as it just passes through the front end, again, as I said, you might do all the work in the right way, where you're billing it right, you're coding it right, you're submitting it right. It just doesn't go to the right person. And that's why it's so important to really get those insights, because you can do a very high-level retrospective analysis and really figure out within your L system, if you have multiple facilities, where are these issues occurring? Where are you being denied because you have sent the claim to the wrong insurer? What type of population, what type of facility, what type of service? And if you have all those insights, then you can go and fix them pre-bill upstream. So that, again, it's a good theme where we come back to is deploying this pre-bill and post-bill is so key, because if you just do pre-bill in a very blind type of way, you don't even know what's going on at the back end. So I think
Right.
we see that a lot, and many of our customers that they use MDaudit is we use something called denial risks, which exposes basically where your risks are when it comes to denials based on what the insurers send you back, and it does that at scale. To give an example, the customers can really look at millions and millions of rows of claims and really look for patterns in those claims, where these type of denials are being happening for, let's say, coverage.
Right.
They can do a quick analysis and then basically go and double down on specific service lines, specific facilities, or even specific payers who are denying this. But that's the key. And just to kind of summarize it, I would say that's where I call it as that's the analytical piece of RCM, where a lot of L systems are really trying to get very strong at, because once you get that strong, it's almost like your analytical brain is pushing your transactional brain. Like those are the two different equations of the puzzle. And if you have that set, then you can be very precise in terms of your corrective actions and fixes.
One thing I've always been curious about is the payer side. So you are submitting claims, or your customers are submitting so many claims to every possible kind of payer. And is there a wide variation on the payer side as to, I don't know if the right word is strict or tight, or
Yep.
or if a claim will pass with one of them, would they pass for all the payers, or is there a lot of variation?
Yeah. I mean, you have heard about this whole AI arms race between payers and providers. We see that a lot, right? And I think that we have a lot of providers who are adopting AI. One area where they're really applying AI is denials appeals.
Yes.
And I think those are great areas to kind of really apply AI to, because it's heavily administrative. You have a timely filing limit. You can only go through so much of claims. But also there are practical difficulties on the payer side, because at the end of the day, I tell people like, okay, just because you submit 4,000 claims a minute through AI doesn't mean that the payers are going to pay 4,000 claims a minute, because ultimately the economics of the business is the medical loss ratio has been going up for the payers because they only have a finite premium pool.
Yes.
They can't pay every single claim that you submit. So the question is, they're always going to be looking for areas to figure out where they can push back. And one area where we have seen a trend is what we call it as a multi-category denial. And what it means is you send the claim out, you are seeing a coding related denial, you fix the coding, you kind of submit it back, and then before you know, you get questions around why did you perform the service. So I think our biggest advice to providers are, I mean, you see that the health systems are very amplifying the use of AI, because it's something which is inevitable because of efficiencies and margin concerns.
Yes.
But at the same time, this is why it's important to attack the right problem with the highest reward, because you just need to understand payer behavior. And once you understand payer behavior, then you're able to at least kind of model and simulate what you want to do on the provider side. I think that's the biggest insight we tell our customers is, have you invested in solutions that helps you model payer behavior at scale?
Oh, wow. Yeah. And I hadn't heard that term, but I'm sure there is a race from both sides.
Absolutely. I think it is. And a lot of people have kind of envisioned the model where there are like AI on both sides talking to each other and then trying to submit claims and adjudicate claims in real time. And that's going to be fascinating to look as it plays out. But we are still in the process of getting to that. And it's gonna take, I would say, a few more years, if not months, to get there.
And, kind of from the payer side, inefficiencies may be to their benefit.
Yeah, so I think inefficiencies and not being reactive too, right? Like I think that's the key thing, because I almost think that, the more the health systems are worrying about each transactional claim and not really looking at what's happening at the systemic level.
Sure.
It's to the benefit because of the fact that you're just like looking at one claim at a time and
Sure.
you're trying to address the concern and probably you're repeating the same thing a million times. And that's one of the reasons that the whole approach of being data driven and being proactive really helps. It doesn't mean you're going to solve every single denial problem you have, but it really puts you on a path where you can make some sustainable incremental progress towards solving the most critical problems that you have.
Ritesh, before we totally run out of time, please let us know how our listeners can find out more about MDaudit and your services. How do they get in touch?
So we have a great website called www.mdaudit.com. You can find a lot of information about our products, but we also have a great LinkedIn page that you can subscribe. We have something called the Coding Corner, which we publish every week, where we produce insights on different folks who can use some of the insights. So I'd say those are the two primary resources, our LinkedIn page, and you can go to our website and you'll find a lot of resources and white papers.
Okay.
And if you need more information, you can contact us.
That's at MDaudit.com. Well, to our audience, thanks for joining me on this episode of the Tate Chronicles. And of course, a special salute to my guest today. We've talked a few times, Ritesh Ramesh. Thanks for coming aboard today. Always good to talk to you.
Thanks, Jim. It was great talking to you.
Tate Chronicles transmission ending now.